Okay, thanks very much. Thanks for the introduction earlier. And I'm going to introduce clinical research our group in PMRI, Pain Management Research Institute, is doing with one subpopulation of the opioid deprescribing space, which is people with chronic non-malignant pain who've been on long-term opioid therapy. In some cases, they've been on it for decades and often at very high doses, and they're now being told by their prescriber that they have to, well, they're either have the option or instructed to reduce their dose or even stop it, and presenting a number of clinical challenges. So chronic pain is a big problem. It's pain that lasts longer than it takes tissues that are damaged to normally heal up. So therefore, in many cases, there's no clear evidence of tissue damage that's persisting, or else if there is, there's no treatment available for it. And so it's combined with the pain that it causes, it's a great source of excessive suffering for people. And it's because it's been difficult to treat, it's been very challenging. So some well-meaning but misguided pain specialists in the US in the 1990s thought, well, opioids work for cancer pain and palliative care. There's no reason why we can't use them for chronic non-malignant pain. But unfortunately, that was a mistake that's had terrible, it really caught on because now it was seen as a simple single pharmacological solution to this difficult problem, but it was a mistake and it's had terrible consequences, not only in America, but around the world, including in Australia. And so it was a mistake because opioids long-term aren't very effective. They may work for 6 or 12 months, but they lose their effect after that. But if you keep taking them, they continue to have adverse effects, not only the usual side effects like constipation and nausea, but in about 10% of people, they can get addicted, accidentally overdose and die. And in the year 2010, as the little graph shows, we crossed the Rubicon in Australia where opioids surpassed car accidents as a leading cause of accidental death, and that hasn't returned back to normal yet, or to the previous yet. Before going on, I just want to introduce this concept of oral morphine equivalence for the rest of my talk to make sense. So morphine's kind of like the US dollar with foreign exchange. We use it as the benchmark. And fortunately, these things don't fluctuate each day. They're set in the stone, so we don't have to listen to the news to find out what it's going to be today. But anyway, so morphine is one, fentanyl is 75 times stronger than morphine, oral pethidine is 1/10. So there's a big range. Commonly used oxycodone is 50% stronger than morphine. So when we want to look at studies and surveys of opioid usage, we can convert them to oral morphine equivalents. So 10 milligrams of oxycodone would be 15 milligrams of oral morphine equivalents. And so I'm sorry, this is from the paper. It doesn't project very well, but this slide is showing the like a linear relationship between the daily OME and opioid mortality in people taking long-term opioids for chronic pain. It's Canadian data from more than 10 years ago, but compared to people taking less than 20 OME a day, people taking more than 90 are double the risk of dying. In the next 2 years, people taking more than 200 are 3 times the risk of dying. To put it into local context, one survey of people with chronic pain using opioids in New South Wales has shown that 40% of people are taking more than 90, so double the risk, 15% at triple the risk. So, you know, this is causing a major public health problem, and not surprisingly, there's been a regulatory response to it. Firstly, from the CDC in the US, where they brought out guidelines in 2016. TGA followed suit in 2019, and most other industrialized countries have got guidelines like this now. And they all more or less say the same thing, essentially that it's not really a good idea to put people with chronic pain on long-term opioids anymore. And so what do we do with what we call these so-called legacy patients who are on it from before? And the recommendations are if they're taking more than 90 milligrams, well, they should be taking less than 90 milligrams to lower that risk. And if they're on more than 90, then it's really got to be a good reason to keep them on that, and it should be reduced unless the benefits would really outweigh the ongoing harms. So that's the regulatory piece, but like is often the case, the policy precedes the science. And in fact, when you read particularly the the background document from the CDC, the evidence is currently weak on how you taper, how fast you reduce it, and whether or not it does improve outcomes. CDC originally recommended 10% reduction per week, but this is clearly too aggressive. In Australia, we're now recommending a monthly reduction of 10 to 25%, and if the patient isn't able to stick with that, then the whole tapering schedule needs to be reviewed. So anyway, there's, you know, like we was like I think Jen was saying at the beginning, you know, this creates a kind of a difficult situation where patients who've been on something for a long time are now having the doctor turn around and saying you shouldn't be taking it anymore. So they're frightened their pain will flare up. They're frightened that they might withdraw. And in the case of the prescriber, they're not sure, as the little figure shows, easy to go up the analgesic ladder, harder to come down it. They don't know what alternatives are available or how to apply them. So it leads to difficult conversations and dissatisfied patients. And in a worst case scenario, you know, this pain specialist was murdered by the husband of a patient he had an opioid disagreement with earlier in the day. The husband shot him dead in the car park when he came out of the office in the evening. So something we want to avoid happening again. So it raises a number of research questions. And with the limited time remaining, I'm just going to focus on one. And I think my colleague Claire in the next talk is going to talk about some of the other ones. But I just want to talk about the evidence for the alternatives to opioids for managing chronic pain. So we've just completed a systematic review that's been accepted by the BMJ. And we identified 160 articles with 36 that were randomized controlled trials or non-randomized control studies that could contribute to the quantitative synthesis. And we asked two questions: what dose reduction or chance of discontinuing is achieved with these alternatives for people who are on opioids? And secondly, from the patient's perspective, what happens to their pain, their function, and their mood? Because of the disparate research, we conveniently grouped the different interventions into 5 clinical categories. So other non-opioid drugs or devices like spinal cord stimulators, complementary therapies like acupuncture or massage, opioid replacement therapy, pain self-management, and then just straight deprescribing without any alternatives. And it turned out the best evidence is for cognitive behavioral therapy-based pain self-management programs. And we've got moderately confident level now that these pain self-management programs, participants are 3 times more likely to discontinue their opioid than people in the control group. And as the forest plot at the bottom shows, the mean difference in the opioid dose between the intervention group having the pain self-management program and the control group is an extra 14 milligram reduction per day. The other kind of interventions, their evidence is less strong and they're less effective. So this would be the main thing to be recommending now. In terms of patient outcomes, so yeah, the evidence isn't as good. Many of these studies are not actually measured. They're purely looking at the pill count. And so we have low to very low confidence evidence that, but I guess good news is that you do see small improvements in clinical outcomes with these other, with these alternative approaches, probably because opioids are contributing to not only side effects, but also some possibly opioid-induced hyperalgesia. So that's my final slide. And because of COVID, we haven't been able to meet for dinner or on the grass. So we've just got this screenshot from our recent talk. But I'd like to thank Amy, Ali, Michael, Nick, as well as Claire, who's speaking next, and the philanthropic foundations who've been funding our work so